Guys, this is Charles. I'm one of the surgeons at Southpaws. Today, we are re-operating on a patient that was cut elsewhere for grade 1 soft tissue sarcoma. Margins came back incomplete. So this is the previous surgical scar here. Margins came back incomplete. And so we offered options including just waiting to see if it came back versus radiation therapy. Concerned about radiation therapy because the sciatic nerve runs right in the area here, versus metronomic chemotherapy, which would be for the life of the dog and recommended. Now, when we look at our recut, you'll see that this is our previous surgical scar. And so I'm going to have to go around the entire surgical scar as if it were a brand new tumor. Okay, so I have to cut the whole thing with 2 to 3 centimeter margins. So that's the first important lesson here that we need to take. Now, as far as closure is concerned, I don't think I'll have enough skin here for primary closure, and so I'll probably use a flank fold flap coming from right here, like this. And so that is the plan. Anyway, so probably coming up just like this, and then with a bridge incision right there. So that is the intended flap that we are going to do. And a couple of hellos from India, and I don't know where the other one is. That's great. Anyway, so we'll go ahead and get started. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so that when we live stream, you'll get a little ding on your phone. You can stop whatever you're doing and come and watch the live stream. So the other important thing here is that we are going to go deep as well. And so we're going to get not only wide margins, but we're going to have to take muscle underneath. And that muscle is going to be biceps femoris laterally and probably semitendinosus medially. That cautery is very powerful. See, maybe we'll turn that down to about 25, please. So normally we have electrocautery set on 30, but in some patients, because of the skin contact with the ground plate, that kind of thing, it seems like it's stronger or more powerful than other patients. So just coming around the corner here, there's some discussion about the possibility of amputating the tail and using that as a skin flap, and that's certainly a possibility. The owners were reluctant to lose the tail, and also I think that the flank fold flap is just easier and a bit more robust. Primary care vet, when they were cutting this, were concerned about tumor extending down between muscle bellies and stuff, and we recommended a CT scan, but due to financial constraints, the owner has elected not to do that. But even in cases where they can't afford a CT scan, we strongly recommend at least doing a chest x-ray, because even though they're unlikely to spread, if you did have an incident where you did have secondary spread and you didn't do that chest x-ray, if that developed, a month down the road or something, you'd feel bad for having put the dog through the surgery and the owners through the expense and that kind of thing. So and it's possible that we are going to encounter the sciatic nerve as we're cutting. So it's a pretty good view. We've got a hello from South Korea, Portugal, Costa Rica, Orange County, California, another Costa Rica, Delhi, and Northern California. That's exciting.
The whole world is watching you.
What's that?
So the whole world is watching you.
Yeah.
That's great.
don't know why I don't get nervous.
It's experience.
Probably should be nervous. So that twitching is because I'm in proximity to the sciatic nerve. All right, how are we going here? So I'm going to have to take some muscle fascia here. That's biceps femoris right there. That's all right. Thank you. That muscle twitching we're getting is involuntary, just direct muscle stimulation. So don't worry, the patient isn't feeling anything. We always get some viewers that berate me for operating on a dog that's awake, when in fact it's not awake at all. Okay, so that's the biceps femoris that I'm through here. Again, that twitching is just involuntary, direct muscle stimulation. So sciatic nerve is just sitting right there. I don't know if you guys can see that, right in there. So coming up to the greater trochanter right there. And this dog is not going to suffer any ill effects from the removal of this muscle as far as long-term function is concerned. Can I get ligature, please? Good old lazy ligature. Hi from Florida. Kerala. I have been to Kerala. I loved Kerala. India. Oh, it stopped. Oh, there it goes. Where is it? All right, so now we need to get a fascial plan here of semitendinosus. So that's coming down to ischiatic tuberosity there. Okay. So that's our excision there. Again, that's biceps femoris there, semitendinosus, semimembranosus there, ischiatic tuberosity there, greater trochanter is there, ischiatic tuberosity there, biceps femoris, semitendinosus, semimembranosus. Sciatic nerve is just sitting right in there. So anyway, so that's the excision. That's the easy bit. And now we're going to have to elevate our flap here to close that. Just see if there are any questions. I don't work with Dr. Sean Gallivan. I haven't heard of him before. There was a question about that on the stream. All right, so let's just see here. Actually, probably don't need it all that flat. I'm going to cut that a little bit short here. So that's my bridge incision right here. Coming down into the groin, down here. Can I please get mepivacaine? Thank you. Hey? Okay. All righty.
There's a question from someone who I'm guessing isn't in the veterinary profession, asking if cutting into an animal feels like cutting into a steak.
We'll just ignore that question. Yep. See those nice healthy blood vessels in there? So then I'm going to use this to close the defect here, and then we'll flip this around here, close the rest of the defect up there. All right, so can I get some 2O PDS, please? Thank you. And I'll take some 3O PDS, please, as well. All right, so now we're going to close the donor site first, or at least get started on that.
Question about why we don't use a vacuum when using military quarters to that extent.
So there's some concern about the smoke plume being carcinogenic. And some people, like even some of my interns, like us to evacuate the smoke plume. I don't have any problem with that. There was a study that was done that showed that if you smoked a full gram of tissue and converted it into electric cautery smoked and breathed the whole thing in the equivalent would be 1 cigarette. That's a whole gram of vaporized tissue. And so I think that that's pretty low risk. And the other issue is that if it was really associated with an increased risk of cancer, then you'd have a lot more cancer amongst surgeons that don't evacuate the smoke plume. And so, look, I don't have a problem with evacuating it if one of my staff is uncomfortable with it, but it's not something that I feel like is necessary. But I mean, I guess if you're just trying to minimize risk any way possible, I guess it makes sense. But I think that the risk in actuality is very low. All right, so stretch that out a little bit more here.
Question: if we use just a regular ligature machine, or if it's forced triad?
So LigaSure is forced triad. It's made by Covidian. And so that's the machine that we use.
Another question about how common dehiscence is with flaps.
About 15% risk of dehiscence with a flank fold flap. Probably not quite that much with flank fold, but with normal axial pattern flaps, it's about 15%. We'll cut both of them. Yep. I'm probably not going to use this entire flap up here proximally.
Quick question about where you're from, Charles.
I was born in Connecticut, and I grew up all over the East Coast of the U.S. Went to vet school in University of Florida. Went to high school in Florida. Did my internship at the Animal Medical Center in New York City. Did my residency and master's degree at Virginia Tech in Blacksburg, which was a sleepy little college town that very tragically was rocked by that horrible mass shooting where 38 people were killed. Nobody had ever heard of Blacksburg until then.
What post-op analgesics will you be using in this case?
So we've done a local block, and then we'll use probably methadone or fentanyl, depending on how uncomfortable it is. We'll put a fentanyl patch on it. And then send it home with anti-inflammatories as well.
Someone says you've really taken on the Australian accent.
Crikey.
And one other question about if you recommend using any types of drain systems in these types of surgeries.
I would not use a drain in this unless I was concerned about continued oozing from the bed. I don't like to use drains in anything really. And Jackson Pratt drains, if you're going to use one, use a Jackson Pratt and never use a Penrose drain. Throw out all of your Penrose drains unless you're going to use them to retract blood vessels and nerves. So I'm just tacking this down until the point that Jeff can take over. I've made a mistake here. I've looped around the neck. Jeff, do you want to close that? Yeah. So after my surgical residency, I did a cardiac surgery fellowship in Auburn, Alabama, where I did just cardiac research surgery. Worked for, where my salary was paid by CPI, which was Cardioverting Pacemakers Incorporated, which is a company that makes pacemakers that are implantable defibrillators. And so that was my main project, was working with CPI, and then I also did a lot of research in models of heart failure. And then I went to Colorado State and did a surgical oncology fellowship for 1.5 years, and then I was on faculty as an orthopedic surgeon at CSU for a year before I went back to Virginia and opened up a surgical referral practice there. So I'm just doing little tacking sutures, little simple interrupted buried sutures, just to get the spacing on the flap correct, so we get the fewest dog ears and the best coverage of the flap. I'm just doing a sub-Q first, and then, yeah, that's great. And basically, I'm just getting to the point that I can leave and let Jeff take over and get out of his way, so he can do a better cosmetic job than I can. Okay. Thank you. It's a big head. I am a surgeon. And it's really important when you're doing any kind of axial pattern flaps that you not tack the flap down in the middle to reduce dead space, because you can inadvertently damage the feeder blood vessel. Can I get some more 3.0 PDS, please? That's looking pretty good there. Question about whether this could cause subcutaneous infiltration. Generally not. I mean, we worry about, with the initial tumor, that it could infiltrate down to the level of the muscle. And so that's why we do a muscle fascial plane deep to the tumor. But at this point, hopefully we've gotten clean margins on it, so there's no tumor left. And so it should be unlikely that we're going to get further infiltration. My recurrence rate with soft tissue sarcomas is about 1%. Except for oral fibrosarcomas, which have a very high recurrence rate in my hands. I think in anybody's hands. Okay. Thank you. I saw a terrible pun today, which was, of all the inventions over the last 100 years, I reckon the dry erase board is the most remarkable. All right, I think I'm going to leave this for Jeff to do whatever you think, skin or intradermal. Although around, I'll come over and see if there are any questions that I haven't answered. So go back up to the top here. Augusta, Georgia, Northern California, Delhi, Costa Rica, Seoul, Portugal, Ukraine. So the question about the vacuuming the carcinogenic fumes, Kerala, Florida, Illinois, New York, Alberta. So regarding tips, make sure you know your anatomy. Review your anatomy before you go to surgery. Make sure you're comfortable with that axial pattern flap or the flank fold flap. You can practice on a cadaver to start with. This is not the same dog as 2 streams ago, although it has the same problem, and I'm doing another one with the same problem today, which will have the absolutely identical flap. We are in Australia. There's a question about where we're filming, so we're in Melbourne, Australia. And dehiscence we talked about. And post-op analgesia we talked about already from Long Island, New York. We do ENT cases. So I do a lot of upper airway surgery, particularly for laryngeal paralysis and brachycephalic airway surgery. Don't like using drains because you don't need them, number one. And number two, it increases your risk of infection. So we don't use drains unless it's absolutely necessary. Regarding is it easy to practice in Australia, if you have a degree from an AVA or AVMA, American Veterinary Medical Association accredited university, then it's very easy to practice in Australia. If you don't, then it's tricky. You have to do about 2 years of additional examination and stuff. So that's not easy. Looking down, so we occasionally will tack down to the muscles just on the edges, but we don't normally tack down the flap. Again, because of concern for damaging the blood vessel. Video camera that I use is a Canon, just a prosumer Canon video camera. See if I can tell which one it is. Canon, I don't know which number it is though. I'm just looking at it right now. Oh, a Legria HFG30. It's about a 12-year-old camera, but it's the best camera I've found. I've been through about 5 or 6 different cameras, and this is the best one that I have found. Next question, chemotherapy. We won't do any chemotherapy in this because we're going to get a clean margin and it's a low-grade tumor. Saromas rarely develop in this location with axial pattern flaps, so that's not a major concern. Let's see. And it is the same flank fold flap, not the same patient though, but it is the same flap that we did a couple of days ago. And so it's the most common flap that I do. And I have another one coming up this afternoon as well. We do use Elizabethan collars on all of these, just to keep them from self-traumatizing. The dog ear on the thorax, let's see how that looks. That'll go away as the skin stretches. That should not be a problem. And we use ligature a lot. We've used it in this case, I think, a couple of different times. So anyway, I'm going to go ahead and end the live stream now. Thank you very much for watching. I will possibly live stream the one that's just like this later on, although it's going to be basically the same story. Anyway, thanks again for watching. Don't forget to